Thank you so much, Dr. Hauser. What an amazing presentation. Thank you. I had thought at one point about maybe retiring, but there's too much exciting things going on. So at this point, we'll just keep working. And again, as Dr. Hauser said, thank you so much to the National MS Society. I know many of you are involved in the bikes and the walks and the golf outings and all kinds of other activities that the MS Society is actively promoting. And I think sometimes when you wonder, I'm on my 3rd mile and I'm really wearing out, and where the heck is this money going to, and what things are happening? Wow, look at the kinds of things that are possible with the bright minds and the will and the enthusiasm to go beyond what many of us had ever envisioned, I'm sure. At this point, what I'd like to do, again, is thank Dr. Hauser for giving us a good idea of what the future holds for MS. And what I'd like to do also is ask all of our panelists to please join us now up on the stage. Also, as I had mentioned earlier, each of you in the audience have the question cards at your tables. Please write down your questions as legibly as possible. And also, please just raise your hand with the question card in it. Each of our volunteers who are strategically placed throughout the room will be around to pick up all of your question cards. There we go. I knew we had our panelists coming up from a number of different areas. There we go, Dr. Derwinskis. Okay, I'm just kind of waiting for you to get in order so I can introduce everyone. So each of our audience members knows who's who, and again, please just raise your hands with your question cards. I'll be taking them from our volunteers. So to introduce our panel, to my immediate right, as you well know, we have Dr. Stephen Hauser. To his right is Dr. Joy Derwinskis. To her right is Dr. Jacqueline Bernard. And to her right is Dr. Susan Rubin. And to her right on the end is Dr. Matthew McCoy. Thank you.
The first question, can you hear me? The first question is, what is the difference between MS being a genetic disease but not being considered hereditary? So in general, these mean the same things. If a disease is genetic, heredity, which means DNA, is probably the cause. But one of the science is always getting more complicated. And when we thought that we had the answers that were finally to a question, we now can sequence all the DNA. Is the problem over? The problem has just begun, and there's a new level of challenge that we face. After sequencing the DNA, it became clear that this wasn't the whole story, that there are changes to what are called regulatory elements. They become methylated for the scientists here. And that can happen as a permanent change to our hereditary inheritance. And that can happen, for example, in utero. And when that happens, it turns genes on and off and changes how they function. This is a field called epigenetics. And we know that there are differences, there are risks for MS that come during the pregnancy period and that are not due to genetics but are inherited and relate to epigenetic changes. So in that case, the problem isn't genetic but is inherited. So it gets more complicated but also more exciting and more hopeful that we will find even more causes of why MS tends to run in families. Sure. You want me to?
Yeah, sure.
Why don't we let someone else? Yeah, great.
I guess I have a question that was given. What would be an optimum environment for dealing with MS? I guess not the Chicago summer that we had this past summer would be optimal. You know, so obviously environment, I guess that would encompass a lot of different things, but, you know, obviously are, you know, avoiding heat if people are heat sensitive, avoiding stress. Wouldn't that be nice if we could avoid stress in our lives? Don't smoke, take care of yourself, you know, active life, eating healthy. I think that would be, I don't know if anyone has any other thoughts, but.
Optimism. Yeah. Really important. It's important for the immune system also. You can even learn to fake being optimistic.
If I could just echo the comment about smoking, we now have more and more data that actually we can arm ourselves with that tells us that smoking is associated with increased progression, rate of progression, increased risk of relapses, on and on. So we can actually tell you with some good science behind it that smoking is not a good thing. So that's an important environmental factor. I'm sorry. So the next question, which we had many of these last year, all about vitamin D. What is a good vitamin D level? How much should we be taking? What are normal levels? And I encourage the other members of the panel to chime in. You've heard Dr. Hauser said we like to see 50 to 60. It does vary from lab to lab. Officially normal in at least our lab is 30 or above. But again, there is a lot of science that tells us that vitamin D deficiency is associated with increased risk of relapses, increased onset of disease, et cetera. So we like to see at least above 30, 50 to 60 is better. And probably a good idea to check and see what your level is once you've started therapy. As with many vitamins, there's probably such a thing as too much of a good thing with vitamin D. What that upper limit is, I don't think has been clearly defined yet, but probably good to take a look at what your level is after you're on therapy as well. Does anyone else want to add to that?
Okay, is this one on? Yeah. Can you hear me? Good. Should people with MS get vaccinations for whooping cough? Ooh, there it goes. All right, let's start again. Should people with MS get vaccinations for whooping cough, shingles, pneumonia? And this person did not put the flu shot on here, which surprised me a little bit. So in general, we do recommend that our patients with MS get their vaccinations because it's important to protect against these illnesses because they can actually aggravate the disease, and actually being sick with these diseases is clearly worse than the risk from the vaccinations themselves. Now, you do have to be a little careful with live viruses, though, especially if you're on an immune suppressing medication. So some of our second line and third line therapies that Dr. Hauser talked about, we need to be careful with the live viruses because of the risk of becoming infected by them. So things like shingles, which I believe is a live virus, We often have patients who are starting medications like Gilenya actually make sure that they are immune to shingles and chickenpox before they get the drug, because we don't want them to have to get the vaccine afterwards. So we want them to get vaccinated ahead of time. But in general, we do recommend, and flu shots in particular, this is the time of year we do recommend that our patients get flu shots. So please don't forget to do that this fall.
One caveat I'll add to that, however, I mean, because probably most hospitals do this, and where if you're coming into the hospital, because it's flu season, they offer the flu shot. But if you're coming into the hospital with an MS exacerbation, that would probably not be the time I would do a flu shot. So usually after you've had an attack or exacerbation, I don't know what everyone else does, but in 4 or 6 weeks before you would get a vaccine, including the flu shot. So I would delay it.
So maybe, Amy, maybe I can do 2 questions. I'll go down and back, like an NFL draft. And did you say you were thinking about retiring? Because I started getting chest pain when you said that.
It was a fleeting thought.
Find a new institution I was going to move. So maybe 2 questions. One is a question about a recently approved drug that was mentioned earlier called the Aubagio or teriflunomide. The question is, what do you know about the medication? So sort of in a nutshell, and I think one of the breakdown sessions is going to go over some of the new therapies, maybe a little bit more in depth. So if you're interested in information on some of the new therapies, there is a breakout session this afternoon. The drug is called Aubagio. Probably the quick one-liner about Aubagio is that it is a pill, so it's an oral medication for the treatment of relapsing forms of multiple sclerosis. It's taken once daily. Its overall effectiveness, it appears to reduce the relapse rate in the 30% range, so about roughly a 30% reduction in relapse rate. As we mentioned, side effects are always a big concern with these medications. Aubagio is a Category X medication, so for young women considering pregnancy, it is probably not a good option. Those medications can cause problems with the baby. So again, I think the big nutshell is about Aubagio. It's a once-a-day pill, appears to have some effectiveness for MS. We do have to think a lot about the side effects with that medication. The second question is in regards to symptomatic management about Botox for urinary issues. So bladder issues are incredibly common in multiple sclerosis, maybe upwards of 80% of people having some problems with bladder function. There's a number of different ways to try to deal with those symptoms. The FDA, within the last, I believe, year, did approve Botox for spastic bladder. So Botox can be effective at reducing urinary symptoms. You do have to have the correct type of bladder dysfunction for it to be effective. In our practice, we have typically referred to the urologist to do urodynamic studies to help us determine if someone is a good candidate for this medication. So it is an option, but it's not necessarily the best for everybody. So meeting with a urologist to see if you have spastic bladder, to see if Botox is an option. If it is an option for you, Botox is administered by the urologist. It's a semi-surgical outpatient procedure. It can be effective at alleviating symptoms for upwards of several months. So I do think it's a great option for people who are good candidates for the medication.
Okay, so my next question was, with all this future exciting new data that Dr. Hauser brought up and trials and imaging studies, will any of it apply to patients with progressive MS? And there is some data, some studies going on looking at treatments with progressive MS. So far, we haven't had anything available specifically to treat progressive disease, but there is a lot of work going on in this area. There's some studies going on that look promising with some of the newer medications that hopefully will be able to show a benefit in progressive disease, because we all agree with all of you that this is an area that really needs some attention, and we really need to do something to help patients if they have primary progressive, or even as they become secondarily progressive after relapsing remitting disease, to really make a difference in the long-term disability that patients experience with MS. So there is a lot of ongoing research, but we don't have the answer for that yet. But a lot of attention is now focused on progression and sort of differentiating that from relapse. And when we get a better understanding of what causes the progression, and if that's different than what we're seeing with relapses, we'll be able to target our treatments to that better.
And if I could just add, there are a couple of trials that are going to be entering patients with secondary progressive MS. There was a large-scale multi-center trial looking at primary progressive MS that's closed entry, looking at Gilenya. Now there will be 2 other trials using something like I like to call Gilenya Light. It's a more selective form of Gilenya for secondary progressive that will probably be starting up early January. That'll be an oral medication for secondary progressive. And then also there's a Tysabri study looking at secondary progressive. So there are some things just about available or available now to enter into. And I can give anyone who's interested in those contact information about that. My other question is, and the answer to this depends on if you're a cup half full, cup half empty person. In your experience, have you found a kind of benign MS? And this is something that we all wish there was such a thing as benign MS, and there probably truly are people who have benign MS, but I guess in this regard, although I'm usually a cup half full person, I'm a cup half empty person because I do worry about my patients who say, could I have benign MS? I always worry that down the road another attack could happen. And so I think most of us tend to view MS as something that can always come back and cause relapses, and we tend to be very surveillant and worry that this is not going to be benign MS. So I know that there are patients with benign MS. I suppose we've all had patients who have the benign form, but we tend to not hope, although we wish all of our patients had benign MS, I think we tend to treat our patients as non-benign MS and always be surveillant for more lesions, re-exam to see if there are new findings on exam, and treat patients as if they do not have benign MS. There are very early forms of MS that can look benign initially, but again, I think we tend not to imagine that that's going to be benign forever. And I certainly welcome any input from the panel on this too. But
yeah, I'll add one thing. I think the problem is that to make a diagnosis of benign MS, we need to be talking to the patient 15 to 20 years after their diagnosis. So up front, it's hard to tell somebody how their disease, because the disease is unpredictable, whether or not, how aggressive or active their disease will be. So I think that's what Dr. Bernard is talking about, that up front we have to treat everybody the same. So
I think also, there was this question about progression that I just answered, and that there's always the risk of some underlying progressive process, and so that even without the attacks that that patients experience, they still could be having slow, sort of indolent progression, and that over time that may end up leading to disability even without recognized attacks. And so we don't ever want to label somebody truly benign just because they're not having attacks. We also need to follow their progression as well.
So my question was, what influence does nutrition have on MS? And I think nutrition plays an important role. The only problem in terms of overall general health and well-being, I'm not certain of any great data at this point for particular diets that have been shown to be of benefit. Years ago, it was kind of the swank diet, this exceedingly low-fat diet. Nowadays, everyone's talking about this anti-inflammatory diet, so gluten-free, dairy-free. There's really not any data for that in MS. I was told there was data in rheumatoid arthritis. I actually looked for it. I didn't find any of the data in rheumatoid arthritis. So, I think I would encourage, I think nutrition is important. There was the other part of this question was that if you eat right, exercise, are in good physical shape, are you less likely to develop MS? I don't know that we have data for that, if anyone's aware of anything. But I think just in general for overall well-being, for all of us, but I also think for MS in general, people will feel better if you are exercising and having an active life and being as fit as possible. I think that contributes. And then the question was that if people modify their diet, do you see a reduction in the severity of attacks or slowdown of disease progression? And that's what I was talking about. We just don't have really any data for that, for particular diets. So just good, healthy living as we all should be doing.
I think we'll ask Dr. Hauser to go ahead and take a couple questions because we've got a lot here for you based on your
there's
presentation, and then we'll
Zach,
move
well,
on.
I have a large number, so maybe we could do a lightning round.
Sounds
And
good.
I would also say that I've been at a few of these before, but there is no question that you all have the best handwriting. These are so easy to read. So let me try to do a few quick. Are there genetic tests today that can help predict MS? You will see in some of these genetic testing companies that ask you to spit into a cup and send them that they have tests that talk about changing the risk for MS. That is true. That is based on some of these studies that I showed you before, but they are not sensitive or specific enough to be useful. So the answer is don't do those yet until we know more. And remember also that environment remains most important. So even the most important MS gene, if you have 2 copies of it, it confers a risk of about 2% or 2.5%, so very low, and the others are much lower than that. So the answer is not yet. Explain the concept of flare-ups every 6 weeks. It just means that when MS is new and untreated, there's one of those new white spots, which is an area of inflammation, loss of myelin, and scarring that forms about every 6 weeks. And most of those are in areas of our brain that are silent. We don't use them, but as they accumulate, they may impair our ability to recover by using those silent pathways. So that's what I meant by disease under the surface every 6 weeks. It's like having high blood pressure, and it's there it's happening more frequently than we measure it in the doctor's office. If tapeworms stop progression, why can't we modify this treatment for MS? A number of people are doing this. Everything from ground tapeworm preparations, but more important, to treating with the chemicals that the tapeworms are producing. Very exciting potential for the future. If you live in an industrial town, does that make you more likely to develop MS? Well, we know that there's something about modern society, and especially Western urbanized society, that has dramatically increased MS risk. 100 years ago, we think that MS was about equally prevalent in men and women. Increasingly over the century, women are more affected than men. New cases of MS, new people with MS, it's more than 3-to-1 women to men. We think that men, the risk for men may be relatively flat, and all of this increases in women. This is one of the great questions to understand. And as we all know, women over the last 100 years are behaving more like men in many ways, from smoking to jobs to eating the same thing, and we are reaching puberty at an earlier level. There are all these differences. There's also something called the hygiene hypothesis. Have any of you ever heard of that? And that means that the immune system likes, in some cases, to be exposed to infections at a very young age. If you're in a cleaner environment, get exposed to at a later age to infections for the first time, like Epstein-Barr virus, the virus of mono, you have a higher risk for having an off-target, unhealthy immune response that could cause autoimmunity. So let your children play in the mud a little bit. Do you think that someone with MS who has had MS over 20 years, the myelin can be repaired? Well, this becomes a problem. This is a problem because over years after the plaque forms, the oligodendrocytes, those undeveloped oligodendrocytes, fade away. The other thing that happens is that the nerves themselves become injured and die. So the problem after 20 years may be more complicated than repairing myelin. And for that problem, we will need engineering, we will need stem cells, we will need working on making the brain plastic, more plasticity.
Thank you, Dr. Hauser.
Maybe one more question,
Go
if
ahead.
that's all right. I'm
That's fine.
sorry for those of you who I've not answered. You said we're a third the way. Does a third mean knowledge or time? I'm talking about knowledge. We have a good feel for inflammation. We have a long way to go for repair and progression. And the time is up to us. The time depends upon the funds and the effort that we as a society place, not only on MS research, but on other disease research. We're equally at the cusp of answers for Alzheimer's disease, but no inadequate funding. And there is a crisis in America that young people are not taking the baton from senior physician scientists who are towards the end of their careers. This is a giant national problem. We're currently putting 1.5% of our healthcare budget into medical research. That's research and development. China is eating our lunch. There were 16,400 plus medical school graduates last year. 31 embarked on a career as a physician scientist in neuroscience. We think across all areas there are only 380 of those 16,000 people doing it. These young people are in debt, the salaries are poor, the careers are uncertain, and they see that society isn't funding this adequately. So I think of all the things that the MS Society does, its advocacy and its support for junior physician scientist programs like the Harry Weaver Award is just so essential. And I would say if there's one thing that needs to grow in the MS Society's portfolio, it's help for great young people who are committed to walking between the clinic and the laboratory. Those are the key people.
Thank you so much, Dr. Hauser. I'd like to make one more run down the panel, and I'll ask that out of all of the cards that I've passed out to each of you, rest assured there's a whole stack of them up here that we didn't get to. I'm going to ask you to choose one of the questions that was presented to you and attempt to give us a brief answer to that, and then we'll finish up.
There's a question about what's the indication that the disease has moved from relapse or remitting to secondary progressive, and that is purely based kind of on clinical and really information from the patient, and are things kind of slowly worsening over time. And I mean, you may still have relapses on top of that, but if things are slowly worsening over time, but by definition, that would be secondary progressive MS.
My question is there any evidence that any of the currently approved therapies do anything to slow progression to secondary progression? And if not, why are we taking these medications? That's a very good question. A lot has to do with how these original studies were designed. In fact, one of the least effective medications out there was designed to look specifically at progression, and it met its primary endpoints. So it depends a little bit on how the design of the study was rolled out. But in general, all these medications decrease inflammation. That is really a primary endpoint for most of these studies, and they do decrease that, and that's associated typically with decreased relapse rates and decreased progression. So there is evidence with all of these medications that they do slow progression, and in fact, at least in one of the therapies, it seems to decrease risk of death. So there's a lot of data that does say that these medications slow progression and in fact prolong life. We just all wish that they were even more spectacular than they are already. So that's what the future's about.
All right, so I had one question on women and their monthly cycle. I'm going to actually save that for our session this afternoon, since we do have a session on gender issues. But so my other two questions, I think I can answer both of those. One question is, what is LDN and can it be used for MS? And then whether you should use vitamin D or D3 for your vitamin D supplement. LDN is low-dose naltrexone, and naltrexone is actually a drug for drug addicts to help them get off for withdrawal symptoms. There have been some anecdotal reports about the use of LDN in MS and the thought that it improved energy or helped nerve conduction, but this has not been shown in studies, and so there's no good data to support its use in multiple sclerosis, just anecdotal reports. In terms of vitamin D versus D3, D3 seems to be absorbed better, so for a lot of people we recommend D3 just because it actually gets higher levels within the system, but regular vitamin D is fine too, and really what needs to be done is to check your levels to see whether you're getting adequate vitamin D and actually caused an increase in your vitamin D levels. So that's probably the most important, is to have that rechecked on the supplements to see whether you're actually getting benefit or not.
Okay, so similar what Dr. Rubin had just mentioned, I have a number of questions about symptomatic management. We do have a breakout session this afternoon that focuses really just on symptomatic management in multiple sclerosis, doesn't talk about therapies for MS. So there is a breakout session going over a number of these types of questions about how to manage the symptoms of MS, not just things like the relapses and MRI data. So just trying to answer a question about Tisabri. The question says that the individual is currently testing positive for the JC virus antibody. What are the chances of that changing? As currently stated by Biogen, once positive, always positive. So Biogen is a company that makes Tisabri, and it's also the company that got the JC virus antibody test approved. Currently in their recommendations, once someone becomes JC virus antibody positive, they're assumed to be positive and acquire the risk of being antibody positive. There is some discussion about individuals who serorevert. There are some people followed in the clinical study who do go from positive to negative to positive to negative, and it's not exactly clear why that is and what that means. But currently, once positive, it's viewed as always being positive. The company is looking at a second generation of that test that will be even more accurate than the current first generation, which is in and of itself a highly accurate test. So currently, your antibody status can be very, very helpful, as was mentioned in Dr. Hauser's lecture, in determining risk for PML with Tisabri, and is a commercially available test that's currently covered by the company.
Well, thank you all so much, to each member of our panel.